Hello, or welcome back to a session. I know it's been a while and I'll try to make this a bit more regularly. So today's session is going to be about hypothyroidism. Um, and in terms of the background, I just pick whatever Microsoft Office kind of offers. So it might vary from video to video. So a little bit of exciting change. So next slide. What is hypothyroidism? It is a lack of thyroid hormones. So if you recall what a thyroid hormone is involved for, it's very involved in our metabolism and our um, metabolic processes. So it's pretty much a slowing down of these metabolic processes that kind of characterize the features of what hypothyroidism is. It's sort of common, 4 in 1,000 per year. And if treated well, its prognosis is actually quite excellent. If you leave it untreated, it can result in heart disease and dementia. And even through the complications, you can see how thyroid hormones affect nearly every cell in our body, and heart disease and the brain is some areas that it can involve. It has an insidious onset, so it's something that you have to kind of keep aware of. The signs tend to be quite subtle and non-specific. So such as patients might come in for cold intolerance, fatigue, dry skin, constipation, and especially presents more in females and particularly those over the age of 40. So you have to keep in mind about possibility of hypothyroidism in these sorts of presentations. And a lovely diagram of the thyroid gland over here. So symptoms. I love these sort of pictures because they really stick in a way. So if you think about it, we'll go through some of the main ones here. We've got tiredness, lethargy, decreased mood, all sort of that fatigue sort of symptom. They don't like the cold. Think about it. Our metabolic processes are shutting down. Our body cannot can't mount a reaction against the cold. So they really don't want to be cold. They can tend to have an increase in weight. Again, decreasing of our metabolic processing. They can get constipated. They can have more heavy and longer periods. Hoarse voice. It can affect your memory. And it's a very big cause of reversible dementia. And it can also cause myalgia, cramps, and weaknesses. And if you can see this picture, some additional stuff is they might have hair loss, so receding hairline. You can see that eyebrows, a thinning of that as well. In severe cases, you can get facial and eyelid edema, and we'll talk a bit about that in the later slides. A thick tongue, again, later signs or that edema sort of signs. Not so much anorexia, but I guess they don't feel hungry. That's correct, actually. And they do have an increased weight, so they kind of go together. They might have brittle nails, menstrual disturbances, and I guess here's more of a late sign. So when you have bradycardia, when you have loss of consciousness or cardiac complications, that's when it's been quite long-standing or severe. These are signs. So symptoms and signs are different. Symptoms is what they kind of present with. Signs is what you kind of spot in your examinations. A useful way is bradycardic. So B is bradycardia, slowing of your heart rate. R, your reflexes tend to react more slowly. A, they can also get cerebral ataxia, which is very interesting to note. And it seems to have an endocrine kind of role component to it, and it's a reversible one as well. Once you fix the underlying issue, the hypothyroidism, it tends to correct. You can have dry skin and thin hair as well. They tend to be quite fatigued, drowsy. They can have cold hands. Ascites, they can have fluid buildup. And you can see in this diagram here, this ascites right here. They can have edema in other places as well, hands, feet. And it's thought to be due to glycosaminoglycans. So this is when, because of these low thyroid hormones, your thyroid, your pituitary gland secretes something called TSH. And it's important to go back to a session about thyroid physiology to revise on that, which I've uploaded. And what it does is TSH wants to stimulate more thyroid hormones, but in fact, it can also stimulate other parts of your body. So your extra fibroblasts and things like that under your skin that can encourage it to increase this production of glycosaminoglycans. And these draw in water and edema, and that's why you can see these peripheral edema as well in their hands and feet. And similar sort of pathophysiology, they can have a more round, puffy face due to that edema. D, I think they've included this just to fit this acronym, but defeated demeanor, sure. I, immobile, but more about ileus, they can have to be constipated. Then C for congestive heart failure. And this can be due to rate related as well. And also, if you think about it, our body starts to, in later stages, can vasoconstrict and shut down blood supply to more peripheral organs, try to conserve it to the central sort of thing. So you've got increased peripheral resistance in our body in terms of our vascular resistance, and our heart rate slowing down as well with our bradycardia. So it's a combination effect, can lead to congestive heart failure as well. Other things we should also think about is neuropathy, myopathy, and sometimes they can have a large goiter, depending on the cause. So thinking about causes, what causes it? So primary hypothyroidism is something due to the thyroid gland. The most common cause is autoimmune lymphocytic thyroiditis. And there's two sort of categories. There's primary atrophic hypothyroidism, very common. It's a diffuse kind of infiltration of these lymphocytic cells, and then that infiltration then leads to atrophy. These patients don't really present with a goiter. Then there's Hashimoto's thyroiditis, and these people do present with the goiter because of this lymphocytic and plasma cell infiltration. And these are more common in females aged 60 to 70. They can be hypothyroid or euthyroid as well. And really, because of this infiltration and this damage that's going on in the thyroid cells, it releases these thyroid hormones in the body, and it can actually have a period of hyperthyroidism. But then that eventually goes into hypo, so low thyroid hormones. Autoantibody titers are very high, so you can test for these in the blood. Other causes, we can think about iodine deficiency. This is worldwide the most common cause. Post-thyroidectomy or radioiodine treatment, so damaged surgery or even radioactive element. And this is purposely done to damage the thyroid gland. So sometimes when you have hyperthyroidism, where you're having too much, you can have radioiodine treatment to actually suppress it. In fact, many of these patients can actually become hypothyroid and then need lifelong thyroid hormone replacement. It can be drug-induced. Anti-thyroid drug makes sense. Drugs that's stopping you from making thyroid hormones. Amiodarone, we'll talk a bit about that. Lithium as well can be toxic to the thyroid gland, and iodine as well, which is interesting because you think that iodine helps support thyroid hormone production, but in excess levels, they can actually be the opposite. Subacute thyroiditis, usually it's quite temporary. So you get a hyperthyroid. Remember, you get damage of the thyroid gland, so you get release of all the hormones, and then you get a hypothyroidism phase. These pictures kind of represent the most the most common cause, iodine deficiency. Iodine is very plentiful in seafood, so I'm sure this beer doesn't have hypothyroidism. In terms of these mountain areas, the soils tend to not have iodine as much, so you could expect in high altitude places to have lower levels of iodine. And in fact, because of these public health measures, most of us actually get iodine in our diet accidentally because we have iodized salt. And if you see in the supermarket, you can see that many of the salts are actually iodine supplemented. Then we got secondary hypothyroidism. So this is when your thyroid gland is actually perfectly normal, but it's actually due to the master control levels, the pituitary gland or the hypothalamus. And this is when you have not enough TSH production usually. And this is quite rare. So in children, craniopharyngiomas, cranial irradiation can be a cause of that. in adults, adenomas, particularly pituitary surgery and irradiation therapy, are important causes to consider. So how do we investigate it? We investigate it by measuring TSH level. And then after we have a TSH level, if it's elevated, we can repeat it with a free T4 level as well. So a thyroxine level. Thyroid autoantibodies should also be ordered as part of the investigation. So anti-thyroglobulin and thyroperoxidase. So examples in Hashimoto's we discussed can be quite elevated as well. Usually we don't image in hypothyroidism unless if we are suspecting some underlying or different causes. So example, you palpate in the thyroid gland and you feel nodules, then you might consider some ultrasound for further imaging of the suspicious structures. When we're thinking about secondary hypothyroidism or central, when we're thinking about if it's a pituitary or hypothalamic pathology, then there are two things we can either consider: have they had a history of a major illness or something that they're going through where the body is kind of compensating for a way by shutting down metabolic processes, and this is a transient recovery from an illness, so it can be quite expected to be hypothyroid in these instances. Or if there are features of pituitary failure or pituitary mass lesions from the history and examination, then we could possibly investigate that further with an MRI. So why do we measure TSH and then free T4? So as you can see, when your free T4 is definitely what we're kind of more focused on, because that's our thyroid hormone. That's the one that, well, this then converts into T3 to then have effects on our body. But if you can see, like, if I was started off at 10 picomoles per liter, and then you go down by 5 units. So let's trace that. This now went from about, how much is that? It's more than halfway, it's about 7. Now what's the next one? It's all the way up to about 50. Can you see that massive jump? 5 units that way translate to about 50 sort of units that way. So as you can see, this sort of graph has a logarithmic kind of pattern relationship to it as well. So this is more sensitive to measure, and we can see results much better using TSH levels. And then we'd of course follow it up with free T4 to know if it's primary or secondary. Well, in terms of treatment, we can think about it in young adults. We can replace with levothyroxine, T4, about 0 to 100 micrograms per 24 hours. It's a daily dose, and it's based on our weight. You might think, why do we give T4? Why don't we give a combination of T4 and T3? Because T3 is a biologically kind of active amount. But studies have actually combined this and actually shown that there is no actually additional benefit from giving T4 and T3. So we usually stick with T4. We adjust this about on a 6-weekly basis, and this is based on clinical state, and we aim to normalize the TSH levels. So it's important to note the half-life. So thyroxine is about 7 days, and thus TSH levels should be checked on a 4-weekly sort of basis. And then once normalized for quite some time, you can then go into 6-monthly and then finally yearly measures as well. And it's important that for these medications, a lot of other drug interactions can occur. So there's some enzyme inducers that we'll talk about that can actually increase metabolism that we should be aware of. In this diagram, I just wanted to illustrate the pathway from TSH to T4 and T3 and how the conversions from T4 goes into T3. And as you can see, predominantly our thyroid gland produces T4, and most of our conversions happen in our peripheral tissues. And studies show that there is no added advantage of having a combined T3, T4 treatment. When you have an elderly patient or patient with an ischemic heart disease as a medical condition, you want to start at lower doses of thyroid hormones because you don't want to aggravate or precipitate an angina episode or a myocardial infarction or a heart attack. And Then we started a much lower dose and we increased every 4 weekly based on the TSH levels that you would measure, and would do it much more cautiously. What are some side effects? So think about it. If you're giving thyroid hormone levels, our side effects usually is overtreatment. So when you have symptoms of increased appetite, fatigue in a way, diarrhea, palpitations, insomnia, and tremors, as you can see, they're kind of opposites of hypothyroidism. You tend to be less hungry with hypothyroidism, and you seem to be more constipated, and you seem to be bradycardic. It's quite the opposite. So this is an indication of overtreatment, and we need to adjust the dosing levels. In patients over 60, we have trying to bring the TSH down to a much lower level can actually lead to osteoporosis and atrial fibrillation. So we might have to consider a higher level threshold of treating them to not such a low level as well. Now, drug interactions. Thyroid hormones can interact with so many things. It can interact with calcium drugs and ferrous, so iron drugs. You can interact with many of the multivitamins, cholecystyrene, PPIs, and all of these are due to reducing absorption of thyroid hormone through the gut. Then there are other medications as well. The oral contraceptive pill, anti-epileptics medications such as these ones, antibiotics such as rifampicin can all increase and induce greater metabolism of our thyroid hormones, and that's not good. That means that thyroid hormones are now, we don't have enough to kind of act on our body and do what they're meant to do. So, and on top of that, it shouldn't be taken with caffeine, soybeans, and fibers from your diet, which can impair absorption. So the general advice is if you want to either have it in the morning, 1 hour before your meal, or have it 4 hours after meal at night. So a bedtime or a morning time dose. And a lot of patients, due to all these sort of restrictions, have poorer compliance. And that is one of the most common reasons to not achieve a euthyroid state, so normal thyroid levels. But there are many studies that have been kind of conducted to see if there should be a weekly dose compared to a daily dose. And a lot of studies, including this one that I've included on the right, and there's a reference on the bottom, show that it is actually quite an effective measure. So this study actually, a lot of the patients actually started off having very different baselines, but it does show that there is definitely control that can be achieved that can be quite effective as well. So the weekly dose actually had higher rates of free T4 and T3 slightly, and also the TSH level is slightly higher as well, which we would want it to be lower in terms of treating hypothyroidism. Some studies actually show that the TSH is elevated, just like this one, with higher and to normal free T4, which is actually quite illustrated right here as well. So it can be quite effective. However, we do like the daily dose because of the better control, and however, it's definitely an option in patients with poorer compliance. What is subclinical hypothyroidism? This is when you have a higher TSH, which means that your thyroid gland isn't producing enough thyroid hormones, but your actual thyroid hormones are actually quite normal, and the patients actually have no symptoms. And there is quite a significant proportion of our general population, 4 to 8%, and even larger in over 60 years of age, have subclinical hypothyroidism. And the risk of progression is about 4 to 18%, and it is based on a bunch of risk factors. So higher TSH levels is correlated with a greater risk of progression. If you've got TPO antibodies, if you have a goiter, if you've had radioiodine ablation or any sort of radiation or chronic lithium therapy, these all predispose you to have a greater conversion into overt hypothyroidism. So the first thing is we need to confirm if this is a persistent raise or whether this is just a one-off thing, and then have a low threshold for supervised treatment. There is a bit of controversy in terms of treating it or non-treating it. because treatment didn't actually improve survival. However, it did actually improve in a lot of biomarkers for cardiovascular stuff. So it is definitely a mixed sort of picture into whether we should treat it or not treat it. So the general rule of advice is there isn't really a benefit for treating it unless the TSH is more than 10. This is a very good diagram I retrieved it from RACGP, so the Australian General Practice website, where it goes through how to treat subclinical hypothyroidism. So as you can see, if it's more than 10, trial with treating it. If it's in that iffy range between 5 to 10, then you can do some sort of things. If there's symptoms, then you can do a 3 to 6 month trial. If there is antibodies, again, what do antibodies do? They predispose you to having one. So then we can, again, consider that therapy or even just annually monitor them, depending on the patient. And if it's normal, then I guess following that up routinely would be very important. Another important sort of patient demographics we need to be careful of is pregnancy. So in pregnancy, you've got a fetus and that's growing, a baby that's growing, and it's therefore going to increase your metabolic requirements. And therefore your thyroid function is going to change. It's usually going to increase due to this increased metabolic rate. But then you'll be like, hey, hold on, why is TSH dipping during that first trimester? That's because it correlates with HCG. So this is a hormone that we actually detect for our pregnancy tests. And when it rises, it's actually so similar to TSH chemical properties that it can actually stimulate the thyroid hormone to produce thyroxine. So that's why the TSH actually dips. But then it comes back up after the first trimester. So usually for pregnant women, we encourage iodine supplementations each day. And this is on top of the folic acid as well. And in terms of what sort of problems are there with hypothyroidism in pregnancy? Well, there could be obstetrics. You could have preeclampsia, anemia, prematurity of delivery, lower birth weight for the child, and stillbirth as well. So these are very important things to consider. In fact, low thyroid hormones can actually be associated with impaired fetal brain development. So that's very important to consider, and that's why we need to be careful about how to treat hypothyroidism in pregnancy. And within each sort of section or stage of your pregnancy, there are different cutoff levels. Now we'll talk about amiodarone induced. So why is amiodarone associated with hypothyroidism? It's because it's iodine rich. And we talked about this. We were like, why does iodine lead to hypothyroidism? And that's what we said. If there is an excess level of it, it can actually damage the thyroid gland and lead to hypothyroidism. So only about 2% of these users will actually get thyroid problems from it. And again, that's what we just talked about. It's caused from the toxicity, or it can also occur from the destructive kind of thyroid inflammation that occurs. And glucocorticoids can be helpful in this stage as well. If for some reason amiodarone can't be discontinued because its use is much more important than its effect on the thyroid gland, then we might consider a thyroidectomy. So half-life of amiodarone is about 80 days, so quite a significant number of time. And so it's very important for people that are on amiodarone to check their thyroid levels at least every 6 months. Now we come to our last stages of hypothyroidism. These are more of our extreme manifestations before death. So in terms of hypothyroidism, usually when we are hypothyroid, we can compensate. Our body can do what it can to physiologically compensate and do our day-to-day activities. However, if we get run down with an infection or burns or some sort of systemic problem, it can overwhelm the system and we can actually decompensate. So this is when MYXOEDEMA comes in. So MYXOEDEMA is non-pitting edema of the skin and soft tissues. And MYXOEDEMA COMA is in hypothyroidism where our compensation system is overwhelmed. And it's actually a misnomer where you don't actually need to be in a coma. And also, myxoedema coma is also a misnomer because you don't even have to have myxoedema. You don't need to have non-pitting edema or be comatose. So in this picture, you can see that there is a lot of hair loss. So there must be prolonged hypothyroidism. You can see this periorbital edema for sure over here, and a large tongue due to that edematous tongue. Similar with the nose and the face as well. So that's very important kind of signs to note in this patient. So again, general puffiness, macroglossia, large tongue, ptosis, periorbital edema, and we've noted some of these signs in the previous images. They can have edema in their lower extremities. Remember, hypothyroidism is affected with our mental status as well. You can be hypothermia, you can have blood pressure changes. So when it's compensated, you can actually have diastolic hypertension, because imagine your body's shunting blood away from your peripheral organs to more of the central organs. And when you decompensate all of a sudden, you can become hypotensive. And hypoventilation is also another important one to consider as well. So again, what do we order? Full blood count, urine electrolytes, metabolic panel, and so on and so on. Are important ones are VBGs and our thyroid function tests as well, which are important. So how do we treat it? We admit them straight into ICU. It's all about supportive measures. How can I support this patient for now? Correct the hypovolemia, normalize the electrolytes, and normalize the hypothermia as well. So all important aspects of treating myxoedema coma. And then we also need to consider replacing their thyroid hormone. So thyroid hormone replacement. And an important way is giving T4 through the IV route. If we think there is an infectious precipitant or something that kind of causes it to come on, we can give antibiotics. And hydrocortisone is also an important thing, because myxoedema coma is very similar to how adrenal insufficiency, such as an adrenal crisis, kind of presents. So it's important to start treating with hydrocortisone until we can properly rule it out. So I believe that that is the end of my talk. Thank you so much for listening. And if you haven't already, make sure to subscribe, like and subscribe, and comment down below on what you guys want to see next. All right. Thank you for listening. I'll see you next time. Bye.